Aloha all, and welcome to today's quarterly continuing education webinar, Helping Cancer Patients Cope with Financial and Other Stresses. This session is sponsored by Ho'okele Ikeola Patient Navigation Project, which is a program of Imihale Native Hawaiian Cancer Network. My name is Amanda Allison, and I will be your facilitator today. Jill Oliveira-Gray, PhD, is the Director of Research and Evaluation and the Clinical Supervisor at Iolalahui, Rural Hawaii Behavioral Health. Dr. Oliveira-Gray is a Native Hawaiian Health Scholarship recipient, or was a Native Hawaiian Health Scholarship recipient, who received her doctoral degree in clinical psychology from the University of Hawaii at Manoa Clinical Studies Program in 2001. She completed a postdoctoral fellowship in clinical psychology with a health psychology emphasis at Tripler Army Medical Center in 2002. She worked as the Director of Behavioral Health Services at Na'apu'uwai Native Hawaiian Healthcare System Clinic on the island of Molokai from 2003 to 2010 and joined the Integrated Behavioral Health Services staff at Waimanalo Health Center in 2008. She was a member of the Committee on Rural Health within the American Psychological Association 2003 to 2006, served on the Ron Levant Presidential Task Force on Enhancing Diversity in the American Psychological Association, and was president of the Hawaii Psychological Association in 2010. Since 2007, she has served on the board of directors for Alulike Incorporated, a nonprofit organization dedicated to improve the social and economic self-sufficiency for Native Hawaiians. She is currently the board president. She's a member of the Hawaii State Board of Pharmacy. She's interested in research on effective treatments for a broad range of psychological disorders and seen in community health and primary care settings, and culturally responsive research and service delivery models for Native Hawaiians and or other medically served populations. And so we're really happy to have her here today. So without further ado, take it away, Dr. Oliveira-Gray.
Great, thank you. Very happy to be here. Our organization has been participating in the patient navigator trainings for several years now, but this is the first time that I get to come out and play, so I'm really happy about that and excited to talk with you all. As Amanda read in my bio, I did a health psychology fellowship at Tripler Army Medical Center and worked for a rotation in the oncology unit, and just in thinking about doing this talk today, I started reflecting on that experience, and I know that it was probably one of the most rich learning experiences and satisfying on so many different levels. I worked with an amazing team there and learned so much from the patients as well as the interdisciplinary team members. I got to work with an amazing nurse oncologist, Pat Nishimoto. I don't know if you folks have heard of her. She taught me so much. And she really, when it comes to treating the whole person and really giving someone her undivided attention and really going the extra mile for patients, she really exemplified that, and I'll never forget everything that she taught me. So I'm just really excited to talk with you all today, and I think you guys are the experts in the room about helping patients cope with cancer. I've been, if you heard in my bio, I've been doing a lot of other things, but Iolalahui was established to serve, to expand culturally minded, evidence-based services for medically underserved areas. So we started off as a training program, getting folks out into rural areas primarily, and also working in primary care settings. So I've been very passionate about integrated behavioral health, which is part of that health psychology perspective, where we look at working as an interdisciplinary team to address the whole person, because it's never just about biological or physical, because there's always that interplay between biological, psychological, and social, and others would add onto that cultural and spiritual as just essential domains to consider and to work with when we're helping patients who are coping with chronic diseases, terminal diseases, which are extremely devastating as well. So we're going to focus in on psychological, social factors today for in working with patients with cancer, and going into more depth on the financial stresses, and then moving into looking at hopefully some strategies that I can share with you that might be helpful in dealing with these kinds of issues. But I'd like at that point to hear from you folks too about what you find to be sort of the challenges that you're facing in your work, and then maybe we can kind of then move into kind of what could be even more helpful that I could share with you about, and then we can get into questions earlier than the Q&A period. I think that would be probably most helpful for such a small group rather than me just talking the whole time. I'm not really good at that. So if we can advance the slide. Okay, so our learning objectives today are going to be able to describe psychological concerns, of which there are many, and I'm sure all of you are familiar with them, associated with cancer care, as well as social issues associated with cancer care, and looking specifically, like I said, on the impact of financial stress on the patients as well as families and friends that are coping with cancer. And then finally, to look at some different ways and resources that can be used to help patients and their families and friends cope with all of these issues. Next slide. So what are those psychological and social impacts of cancer on patients, on family members, and friends? Before we kind of dive into that, what have you folks kind of heard the most? Like what really pops out when you hear about psychological concerns that patients may have? What comes up the most in your work? Let me break it down a little bit. So when we talk about like psychological concerns, we're looking at sort of how something like cancer can impact someone's mood, someone's thoughts, as well as their behaviors. So we're looking at sort of those three thoughts, feelings, behaviors when we're talking about psychological factors. And also, how one is impacted both by cancer condition as well as then how that impacts the cancer condition itself. So that's really that interplay between the biopsychosocial that we really need to be mindful of. You thinking about something?
I was recently treated for breast cancer in January, so I felt really hopeless because I'm like the primary caregiver of my sister, so I feel hopeless that I can't help her, so I have to depend on other people to help. So I'm always the primary person, so I just felt hopeless that I couldn't do what I'm supposed to be doing for my family. So so I'm sure everybody, other patients, feel the same way.
Right.
So.
Right. There's that uncertainty, I think, that comes with how is this going to affect me? And
I'm always a positive person, but being able to do the regular stuff that I normally do. That the cancer limited me to.
Yeah.
So just the hopelessness part.
Thank you for sharing that. Anybody else?
Yeah, we find that with, especially with single parents, and they're the women, and they have children, they're actually the breadwinners in the house. They keep asking, like, well, what can I do? Can I just start work even if I'm going through this? And it's difficult, especially if they're going through treatment, to have to continue working, and they have kids that's still in school, and, what do I do? Is there any options I have to assist me through this, because, you have your, your FMLA, everything else, but it's not enough.
Right.
So what do we do to help them with that point?
Right. With that.
They literally come back to work and they're like sick. It's hard to see that.
Absolutely.
That's why I'm here to see what you have.
Yeah. It can, be so disruptive, right? Like, how am I going to continue my life with this now?
And stay strong for their children.
Right, yeah. So we can advance it to the next slide and kind of see some of these things that you guys are picking up on in terms of the emotional, psychological impact. There would be a lot of that worry, the fear of uncertainty about the future. How am I going to handle this and keep up everything that I have to do in my life? Anxiety. There have been some studies that have shown the anxiety peaks right at the time of diagnosis, which makes sense, as well as, again, at the time of, say, invasive surgery or the treatment process starts. But then it can subside sort of as they possibly start to see the end, maybe, of, kind of getting through treatment, and life maybe starts to kind of fall back into place again, but there's still that very critical period when the anxiety spikes and there is a lot of uncertainty, and I think that's when folks like you come into play, where you can help them to feel like there are things that they can do so that they can kind of feel like back in control again, you know, with whatever supportive resources that you guys can provide them. It's interesting with the trauma piece. I don't know how many of you are familiar with the DSM. The DSM-4 is our diagnostic manual that we use to see if folks are meeting criteria for things like depression or PTSD. In the old manual, so they just updated it to the DSM-5. In the old one, they included a medical illness as a type of traumatic event. So if somebody was diagnosed with a life-threatening medical illness, that was considered a traumatic event. Well, they took that out in the new one. So some folks there's mixed thoughts about that. There's some folks that kind of think that it should still be in there, and others that think, well, it is really different than if we're looking at comparing it to other types of trauma, like folks who have been in combat or rape victims. So there's some similarities in terms of that, the anxiety piece, the hyperarousal, the kind of feeling anxious and not knowing what's going to happen. But in the other kinds of trauma cases, there's usually there's a malevolent perpetrator that's really the cause of, and so there's also a lot of avoidance of situations that remind people of a trauma event. Whereas with cancer care, you have a supportive team that's really trying to help you get through what can be initially perceived as a very traumatic event. So in the beginning, it can look similar to other types of trauma responses. So maybe in that acute stage, maybe in that first month after maybe receiving an initial diagnosis, that's when we really want to pay attention to what's happening and really kind of wrap around the person with services, bringing in the family and really attending to all of their needs. And that can really help kind of settle things kind of going forward. But imagine if that kind of attention and support is not there in that critical window of time, that's when things can really kind of spiral and get further, you know, out of control and make all of these things kind of worse. The other thing research has found is that depending on one's sort of mental state, mental status prior to receiving a diagnosis, that really matters. So if somebody has a history prior to a cancer diagnosis of, say, depression or anxiety, having a cancer diagnosis could make that worse. So they're at risk. They're like a vulnerable group. So if you have that information, you know, you can, I don't know what the assessment process is like in the places where you folks work, but if you can get some history information about someone, a biopsychosocial history on them around the time of the diagnosis when that's happening, then that can give you some more valuable information about sort of where this person is going to be in terms of their vulnerability to some of these things. So body image and identity concerns is another huge psychological kind of a factor, just given the many different changes, right, that can be happening to someone's physical sort of capacity, actual body changes with the weight fluctuations, hair loss, body disfigurement, things like that. So those are definitely things that are affecting the way one's seeing themselves, their self-identity, what they're capable of doing. So these are huge changes, huge adjustment sort of issues that are all very normal. So it's good to normalize that for folks, but then allow them to process through that and kind of see it after the processing happens where you can zero in to help them cope with some of those things. So some of that would be, you know, after the normalization and allowing someone to express the emotional part, then you kind of hear the thoughts around that, and then you can help them sort of adjust those thoughts to help change the emotion. We'll talk some more about that stuff when we get into the strategies and whatnot. Sleep problems, very, very prevalent. So this is under psychological factors because a lot of times it's the anxiety or the thoughts that can keep people up at night and really disrupt sleep, amongst other things that can really affect sleep. And the problem is if people aren't getting good sleep, then that's going to just make it really hard. It's a negative cycle, right? It makes it really hard to cope with everything that's on their plate. Pain is probably one of the #1 reported stressors, I think, with cancer patients. Do you guys see that? Does that ring true for you in your experience dealing with pain? And so pain in and of itself has a whole host of its own sort of psychosocial pieces to it. And the thing to zero in on with pain is how somebody is perceiving the meaning of that pain. Because there's a suffering kind of way of thinking when it comes to pain, or sort of anxious or depressed kinds of thoughts when it comes to pain that can make the pain worse and can make the whole experience that much more difficult to deal with. So again, trying to, and this is what you get when you're just talking to someone, right? This is what, when we say process, that we're talking about just allowing for an open-ended conversation to take place, so you can understand just how this individual is really thinking about that. And that's your golden, those are your golden nuggets to really hear how for this individual it's really affecting their thoughts. What does this pain mean? And that's often a good lead-in question to find out about exactly what's going on in their minds, is what does that mean for you? And if someone has a hard time sort of talking about that, you can kind of say, well, with some of my patients, this is what they've said. How is that working for you? Or how is that going for you? Is that similar? Do you kind of resonate with that? Or is there something else going on for you? And usually by that time, they're able to think about what it is for them and be able to share that with you. Grief and loss. Loss for a whole host of things, as you guys already kind of picked up on. Loss of a normal way of life, loss of your own routine, loss of being able to take care, you know, role functioning loss. So the things that you did that made you who you are is going to change. Hopefully not forever, but definitely for a certain period of time. And so helping people adjust to that kind of a loss. Grief, for the patient, also for the family members, if it starts to get into looking like patient may not survive. Increased vulnerability related to hopelessness, and at its worst, hopelessness can turn to having thoughts of suicide. So that's why it's really important to really know if somebody is experiencing a sense of hopelessness. Any questions on the psychological factors? And this might not be an exhaustive list. Did you guys think of anything else that is not on this list? Social factors. So financial strain is second only to pain as a cause of stress. And financial strain is kind of a general stressor for everybody. And then can you imagine going through what you have to go through and the additional burdens that happen during someone's course with cancer. So the financial piece is huge, and I'm glad that we are focusing on that today. I think it's one of those things where you kind of know that it could be happening, but there's so many other things going on that sometimes it gets overlooked. And the research is really calling for that to be a part of, you know, within the interdisciplinary team, and that's why it's so good to have an interdisciplinary team so all of the things can get addressed. But the financial piece is absolutely important to start talking about from very early on. As you folks also kind of highlighted, what happens with the sort of occupational changes that has to happen, inability to work often occurs during actual treatments and whatnot. So that can have an impact on one's finances as well. Other social factors have to do with how their other relationships in their life are being affected. Sexual functioning is also a very, very common and prevalent issue that comes up. Having a spiritual crisis, sort of, why is this happening to me? How could God let this happen? Can be very critical, especially for folks who are very religious to begin with. And then changes to one's goals and view of the future. So when we talk about social factors, think about money, job, people. That's what that sort of includes. Okay, next one. So now we're going to talk about the direct costs associated with cancer as well as related costs. And then there's also, like, they talk about hidden costs, and that's where it's important to sort of, you know, drill down with people to find out what all of those costs might be for someone. So in terms of direct costs, making it to appointments, you know, co-pays, transportation fees, parking fees, all of those things add up. And for the amount of times that people are having to make their medical appointments, you can see how that can quickly become a financial burden. Medications, depending on one's health insurance coverage, sometimes the cost of medications can be prohibitive. Transportation, if one can't drive, then you're looking at sort of other modes of transportation that are pretty costly, you know, things like Handy Van or Medicabs or the bus. All of those things are just extra fees that someone didn't plan for having to, you know, to pay for. Special equipment or supplies, paid help, or sometimes even nursing home. Someone, you know, may not be able to stay in the home and have to look and see how they might be able to afford nursing homes. All of these things can be adding to, right, the stress that somebody is already facing with the treatment end of things or just coping with cancer. Related costs, sometimes having to purchase new clothes due to weight fluctuations, possibly changing what they eat, how they eat, nutritional supplements. These are not, you know, cheap things. And then home care or child care. If, you know, you are not able to function in those capacities, how are we going to, you know, what are we going to do to step in and kind of help with that? And so I feel like those are things that in your guys', you know, line of work that can be one of the difficult things to try to help people figure out. Right? Where do they get some extra resources to sort of be able to pay for all of these things? Next slide. And some of the implications of the financial strain would be having to, you know, loss of employment. So not only are you having to incur more costs, but then your income could be going down as well. Reducing hours or flat out losing a job could happen. Or on the flip side, having to take an extra job to manage care fees, which juggling all of that, really difficult. And then family members, the caregivers, you know, also are impacted by having to kind of stretch and change and adjust in order to kind of make ends meet and do the task of helping their loved one as best as they can. Sometimes selling assets has to happen, which we talk about loss and grief that could, you know, add up quite quickly in terms of another way that this is really affecting my life and the change and all of that going on. Thinking about having to take out on a mortgage or another loan. You know, I think, like I said, you know, we do these Stress in America surveys. Our national organization does those, and financial worries are at the top of everybody's list. And again, so having to, that's kind of a given for all of us. But again, when you're coping with cancer, it just makes it that much more difficult. Sorry. No problem. I think we have one more slide before that. Some of the other, one more before that maybe? Oh. Wow. Yeah, I think that's where we were. Yeah. Sorry. Oh, no. Okay, other changes that financial strain can cause is, you know, families having to use up all or most of their savings. And again, back to change. How are we going to adjust in order to be able to kind of continue to cope and survive? Some research has looked at what the impact of financial strain is on one's sort of perceptions about treatment options. And they found that folks with lower financial resources opt for, you know, measures of comfort versus treatment options that could extend their life. That's pretty profound. It's really sad, you know, in a way. So again, what we can do to help resource-wise would be very important and critical. Next slide. So some of the things that the research has borne out to see, you know, what are some of the factors that make the effects of the financial strain worse. So if somebody's in a lot of physiological distress, as well as age, has predicted whether or not their economic needs go unmet, or, you know, whether that's going to be a continual strain on them. Which makes sense. You know, somebody who's younger hasn't had a chance to really maybe amass resources or have options to be able to take out a loan or things like that. They're just sort of getting started with their lives and may not have, you know, been able to earn a big income, have big savings, that kind of thing. And physiological distress, just sort of, you know, it's like competing demands, right? So it's like somebody who's under a lot of physiological distress, you know, just not being able to sort of focus on the problem of how do I fix my finances, or how do I reinforce and buffer myself in that area. Really tough. Again, similar to what I said earlier about one's mental health status predicting how they are able to cope with cancer, similarly with one's pre-financial status, that is going to predict, right. Okay, so kind of breaking that mental health piece down to including financial status. So if somebody is already, you know, maybe lower SES strata, that is going to affect their psychological well-being also after diagnosis. So it's, you know, it's a factor in and of itself that can affect how someone does post-diagnosis. But less was known kind of in the literature, and I was getting updates on this. Less was known about financial circumstances after diagnosis and whether that had a direct effect on psychological health. And in this study, done in 2013, they did find that irregardless of their financial status going into prior to the diagnosis, a third of patients with breast, prostate, and lung cancer reported symptoms of anxiety, depression, or distress 6 months after diagnosis related to the financial strain. And it's interesting, too, this study kind of broke down that term financial. They looked at financial stress and financial strain. Financial stress was anything that was an observable event that occurred, whether it was like loss of employment, having to move, some sort of like actual event, concrete event that happened. They would count that as financial stress. Financial strain was looked at how somebody was perceiving what was going on with their financial situation. So again, bringing up the importance of that meaning, the perception, how people are deriving in their minds the change that's happening in that domain. And so with that report, so about 30% of the patients experiencing more anxiety, depression, or distress due to financial strain or stress that was going on. They also found that talking with the family members was not as helpful in terms of giving all the information regarding, say, financial strain, that it was better to get that information. Information was more accurate coming from the patient themselves. A lot of times maybe that communication is strained between the two, hard to talk about finances, you know, and so really hearing it from the patient to understand whether or not the strain part was there, you need to go to the patient versus just focusing on what the family or taking what the family might be saying, or like I said, the stress part. Like if you know the stress part is happening, then you know it's important to get the strain part coming from the patient. Like how is this really impacting them? This is a good take-home message, I think, because we can move right into like the resource building kind of thing. Okay, you've lost your job, so we need to find something that might be able to support you while you're going through treatment. You know, We can move right into the just kind of fixing things a little bit, putting an action plan together, but we might miss the critical part about the strain, like how is this really affecting you, and allowing somebody to process that. Okay. Which is just what I said here. So addressing the financial concern, stress, and strain, I should have wrote there, is effective in the long term and the short term, and you can do that in a variety of ways. You can be having that conversation yourselves with patients and families. If you sort of feel like there's just so much going on, there's maybe a need for, you know, bringing in some behavioral health support, referring them for stress management counseling. Studies have found that is effective in bringing down the stress and reducing the likelihood of the patient becoming depressed. Financial management counseling could also be very helpful. And looking to different charities or programs or funding or ways that you could bring in more income to help with you know, meeting all the financial needs that there are. that has also been found to help with quality of life and reducing stress for people. Looking at impact of cancer on the health and well-being of family and friends, some concerns are similar to those of patients in terms of the mood, the thoughts, and the behaviors, because as we kind of talked about a little bit ago, family members are also having to make a lot of adjustments. And so they're dealing with change and also dealing with the worry of their loved one. And all of that's going on for them also. Caregiver stress is a huge phenomenon. We address it a lot at our behavioral health. It's sort of something that we do a lot with like people who care for Alzheimer's patients or any kind of chronic disease. So it's a really big, real thing that, you know, that can be going on at the same time what the patient's going through. So good to recognize that and to also reach out and provide resources for caregivers. Caregivers have been found to kind of have really high prevalence of unhealthy behaviors in terms of how they're coping with their stress. They're found to have more smokers, sedentary lifestyle, overeating, poor sleep, and just not managing their stress. So good to focus on that. We need to have healthy caregivers, right, in order to best help all of the patients. Okay, next one. So these are resiliency factors. These are the things that kind of help people, kind of buffer people, can help them rebound, you know, in the face of a lot of stress. Research has found that spirituality and religion is a really significant protective factor or resiliency factor. So harnessing that, if somebody has that already as a strength in their life, harnessing that in, and oftentimes, you know, that can be a way for them to sort of deal with what's going on. Also having close family and friend support, obviously social support is consistently found in the literature to be associated with more positive outcomes for patients struggling with chronic diseases. I had this, my own balloon hypothesis when I was working at Tripler, and we used to round on the inpatient unit for cardiac patients that were just post open heart surgeries. And my hypothesis was the more balloons somebody had in their room, the better off they were going to be. You know, they're going to heal faster, they're going to get out of the hospital within record time, and that was my proxy for knowing how much social support that person had. And so now when I go visit people in the hospital, I always take balloons, just so everybody knows. Obviously financial stability, you know, the more resources one has, then that brings down the impact of the financial stress. Having trust in their providers is really huge in terms of being able to cope with everything. Effective communication skills, how well they understand what's happening. So knowledge is huge, because knowledge can really help somebody feel more in control of what's happening to them. Having a positive outlook, easier said than done after all these lists that we've gone through. But that, again, is sort of the work that we're doing when we're trying to access what their thoughts are, to sort of see how we can help them to sort of shift and possibly have a better outlook if that's necessary for them. Any other protective factors that you guys have seen or that you like really grab onto when you see it in somebody to try to make sure it's maintained and increase it? What helps people to cope better? Sometimes it's already there, so you just have to like pull it out, you know? Sometimes it's not there, and so you have to figure out ways to suggest that, you know, this might be helpful for you.
What do you do with somebody without friend, the family and friend support?
Yeah, support groups, maybe.
Yeah. But, you know, in the home, aftercare, when do you have that?
Yeah, and you got to get...
Patients don't, I have a lot of patients that don't like to go to support groups.
Yeah, it's not for everybody. Yeah, because you know, people come because they want to come. You can't force them, because I tell them that I have a support group, but I said, okay, but they don't show up. So, but so long as I share the information, it's there for them to participate in.
Yeah. Support can look very different for different people. For some people, just having one friend might be all they want. You know, some people are a little bit more on the introverted side anyway, and so finding out, you know, like say that person that goes home to, you know, not very many people in the home, or you know, they might be used to that. It might be okay for them, but you still might want to check in on that and see if there's other things that they might be willing to do. I mean, now there's some, I mean, there's more technology to sort of reach out and find, you know, groups sometimes just through the internet or social media. I've found that some people really, you know, connect with people through their Facebook, you know, like they get to see pictures of family members, or they may not be the one to, like, you know, want to pick up the phone or even meet somebody, but being able to, like, see folks on Facebook sometimes sort of fulfills that social need. It's good nowadays, I think, with technology. We have a little bit more resources, or we can get creative. We can help people problem solve through that if you need to. How about spirituality, religion? How do you guys sort of see that happening with the patients, or try to work that into?
It's hard to talk about religion with them unless they approach you and say, well, you know, one of the funniest things I hear is that, you know, this is God's doing, and I don't know how to answer that. You know what I'm saying?
Yeah.
I might be religious, but how do I handle that kind of a comment? You know, and I get quite a bit of that. But they do turn to religion a lot. They tend to look at things in a sense like what they're going through. Is it really going to work? And then they start doing the web thing and researching, and they want to pull away from what's medically necessary versus, you know, herbal type of things, or, you know, and I'm like, I'm really not into that, so I don't know. I get caught right in between.
Yeah, I saw that a lot.
We get a lot of that, and I'm like, oh my God. So we have the younger generation that have cancer. You're looking at the 23 to 30 that we find right now. I'm trying to cope with. They've been diagnosed invasive ductal carcinoma. Now they're like, I want a second opinion. How much second opinion can you get? You know, so you know they're not really educated as far as what they really have. You know, and so just trying to cope and help them with that is what, you know, pretty much I'm dealing with right now.
Yeah, I think the religion question, especially if they're in that sort of spiritual crisis too, it's tough to talk about.
It is.
What's
it
going
really
on.
is.
Yeah, and I've heard that too. I've heard that, you know, this is what God wants. You know, my quick rule is if it's working for them, if it's helping them to cope, don't need to mess with it. If it seems to be, you know, increasing a sense of any kind of mood, you know.
Right, or depression, you know, like further going into it because why me comes into picture.
Yeah. Then you might recommend, you know, talking with their pastor, or talking with a friend who's from the same, you know, religion.
And you know, you look at that age group, they have family, but a lot of them are independent, they live by themselves, and they're trying to cope with it. They don't want their friends to get involved. I mean, it's just so a mixed feeling right there.
Right, they kind of want to pull away.
Yeah, and then you find them calling you a lot. So you become, you know, their support, and you start digging and looking for options, you know.
Right.
And what I found is, like, if I work with patients that are around that age, and I know that I'm facing future ones, I said, oh, you know, how would you like to even be an advocate to this? You know, oh yeah, I would love to share what I go through if somebody younger or at my age is going through it. So I have that little portfolio where I keep it. And if you run into those type of patients, say, would you feel comfortable talking to somebody who's gone through that?
Yeah.
And it's worked for me.
Kinda,
so you just got to keep strategizing and thinking.
Yeah.
Because there's nobody to reach out for them.
That's a good creativity there.
Yeah, I had to.
Yeah. For that populate that age group. Interesting. Yeah. Okay. Next one. barriers, some challenges. We talked about some already, but you know, anything from there being cultural mismatches to poor communication, to lack of knowledge about their illness or management, not having transportation, again, financial problems, not having health insurance, lack of understanding about psychosocial needs. People don't maybe think that psychosocial support is important. That's a big one too, right? Kind of like you're saying, you know, when they, you know, I don't need that help, or I'm okay, I'm going to do this on my own. That's kind of a challenge. And then not having kind of the knowledge and awareness of what resources are out there. That's what you guys are there for. And then a failure to recognize, treat, or offer referrals for depression or other illnesses related to the illness. And that could be tough too, right? If there's more going on than just the cancer. And then that can be on both the psychological and physical side too. Other barriers? Yeah.
Can you explain what you mean by cultural mismatch?
So, you know, maybe between the team, the treatment team, and the patient. If the patient is from a certain culture and does things in a different way, but possibly feels like that's not being attended to or factored into the way the treatment is going on, then that can cause some, you know, problems. It could reduce trust in the providers, which on the other side is important. Like a resiliency factor is when you feel like you have that trust in your providers. But you know, if you're taking a individual approach to the patient and understanding, you know, the biopsychosocial, cultural, spiritual, then you're getting all that necessary information and hopefully can impart things to the treatment team or treatment providers. You know, somebody comes up with, oh, I heard that this, you know, because of their culture, they're, you know, really, you know, wanting to have all their family in the room today, or, you know, kind of things like that. So kind of helpful.
I had a case like that where the woman was Arabic, and you know, she understood me. I had the husband come in, but he was doing all the talking. So it was like, okay, where do I stand? I had to step back and say, okay, that's a cultural thing, because she really didn't have a say as to her health. You know, he makes the decisions. So it's really interesting to learn Arabic, Micronesians have their own. I mean, every not religion, nationality have their own. So yeah, you get stuck in the middle.
Right. I mean, even language. Yeah, language is kind of a first.
So you end up like, okay, who do I talk to? She's the patient, but he makes a decision. You know. So.
And culture really kind of, you know, it's pervasive across like all the behaviors that somebody's so used to doing, and if you're asking them to change something, it's really going without understanding of how this has become such an ingrained part of their life that there's this cultural component to it, and that's often where there's a mismatch, right? It's like, well, just, you know, stop eating Spam. That's not good for you. It's like, but that's something our family eats, and that's just what we're used to. It's kind of lack of understanding of where some of those behaviors come from, and it's not so easy all the time to change.
Cultural mismatch session.
Yeah.
It's huge here.
Yeah, it is.
How do you see it playing now? You think like local culture, and sometimes maybe providers not necessarily from here having a hard time understanding local ways? Or?
No, I think the providers are pretty good at dealing with the different cultures. But yeah, the cultural, that plays a huge role in how patients get treated. Yeah.
More the doctors, you know.
It's more so with like the Pacific Islanders.
Yeah.
Exactly.
Yeah. Okay, so how can you continue to help? Do more of what you're doing already. So do you folks do screenings at all? Part of, say you kind of maybe identify that somebody, well actually, sort of the value of a screening is you're not going to wait, right? You're going to, because of the literature that we know that there are potential psychological factors that can happen at the time of diagnosis, not waiting until somebody is crumbling in your office to then go, oh God, depression, but asking the questions, earlier on to find out. So kind of being more proactive and more preventive, if you will, would be the value of sort of being aware of what screenings are out there. So in one of the handouts, we often use the PHQ-2 because it's only got 2 items. It's really easy to administer, and it's got a lot of good research that says if somebody says yes to those 2 items, that's a likelihood that they're experiencing more depressive symptoms, and you might want to screen for whether or not more symptoms are there. So there's a PHQ-2 and then there's a PHQ-9. We also included the PCL, which is a trauma screener that's often used in primary care. So in the primary care settings that I've worked in, we put together these kinds of behavioral health screens so that at the time of medical appointments, MAs or even the doctors could administer these screenings, and if someone is in need of behavioral health, then they can just make a quick referral. So I feel like in your settings, this is something that would be kind of beneficial if it's not being done already, just to kind of make it a part of, somehow make it a part of intake paperwork, or I don't know if it already is. Yeah.
Yeah, in the cancer center, the social worker does the distress screening tool.
Oh, okay.
Yeah.
Okay, nice.
And I don't know that you folks in the women's center really have anything. I think it waits till it gets to the cancer center. And I'm not sure, yeah.
What is the,
It helps.
yeah, so you guys are already doing this.
Yeah. Well, by the time patients come to the cancer center,
Uh-huh.
well, on the multidisciplinary side,
Mm-hmm.
some have not been diagnosed yet. They're coming for like nodules. On the med-onc side, they've already been diagnosed. But every new patient that comes in will get a stress thermometer, and it's from 1 to 10,
Mm-hmm.
what their stress level is for that day.
Mm-hmm.
And then if it's above, I think, 4,
Mm-hmm.
then the social worker will meet with the patient,
Talk about what's going on.
about, there's like a bunch of different things on there, like
Mm,
financial, family.
nice.
It's the,
Yeah.
I think it's the NCC and distress thermometer.
So first the thermometer, and then if they're at a 4, then a further, like another scale to find out what areas.
Yeah, but it's a questionnaire.
Yeah, it's a
Yeah.
questionnaire.
It's the same questions.
Yeah,
Yeah.
same question you have on the.
Awesome. Oh shoot, I wish I kind of took a look at that before. So good, that's happening. Yeah, the earlier the better. Like I said, not wanting to wait till somebody is falling apart, but
Yeah.
want to kind of preemptively know what's going on. Yeah. Okay, next slide. And like I've been kind of saying all along, the most important thing to do is to ask and then to listen to the answer. And so I think we're like ready to, jump in with resources, here's what you can do and whatever, but we kind of got to wait before we get there to like really process what's going on for them. So how to get people to talk. So there's an approach called motivational interviewing. Have you guys heard of that? Motivational interviewing, and it's really beautiful in that it's more of a communication tool than anything else, and a way to really help people to express themselves. And as the person doing MI, you kind of learn how to listen in a way that gets them to talk more. So you're not just not saying anything, you're being very intentional about your questions, but you're not barraging them with questions either. In your guys' experience, what kinds of speaking gets people to talk less? How do you get people to not say anything? You might have observed this in another provider thing. Another provider's communication, not yours, but asking yes and no questions. Because they don't have to say anything else. You ask them a question, they go, no. Done. For somebody who's trying to get through a whole list of questions, they might, that might just be the intention and want people to just say no, but you're not getting a lot of rich information. Another speaking style or communication style that gets people to talk less is when you give them advice that's not solicited. So when somebody wants advice, wait till they ask and then give them. But if somebody hasn't asked for it, don't be like, da-da-da-da-da, here's everything you got to do, and because probably they're not ready for that information, you know, and it might just be like going in one ear and out the other. They might be in a whole different frame, a whole different mental space at that moment. If you kind of pick up on some nonverbal cues that somebody's looking at you like deer in headlights, that might be because they're not ready for all that, you know, advice. The kinds of speaking that gets people to talk are the opposite of closed-ended questions, open-ended questions. Tell me more about that. Tell me what's going on for you. You know, so you're not leading them in any particular direction yet. You're just wanting to know and kind of opening the door pretty wide just to see where they land. Because you might even be assuming something, but if you go in too quick, then you might miss something else. So you want to start off as open-endedly as possible when you're trying to gather information. You know, so like even with the distress and the screeners are helpful though, because if they're endorsing certain items, you can just start there and then get them to expand on those items, because at least it's putting you in the ballpark, you know, and it's okay to target and then let them expand on that area. So in the past, we've done like role plays during these trainings to give you guys, you know, chance to try on the open-ended questions for size, but I don't think we're going to have time to do that today. How do you guys feel about open questions? Is that something that you feel like you've worked into your toolbox already in working with folks? Yeah.
I found that open-ended questions often bring in subjects that maybe were not originally addressed.
Helpful or not helpful?
Very helpful.
Okay.
Very, very helpful.
Yeah.
And then, you know, the patient will say something that you maybe did not have any idea about,
yeah,
but is also a barrier now that this patient has
mentioned
it. So
that's like those.
I very much
oh my gosh,
love open-ended questions.
Yeah.
So I was getting a lot more
right.
than what I thought it was going to get.
Exactly. It's like a constant reminder of our own, like, careful of your own assumptions.
Yes.
Yeah. We think we know what's coming next, but we have no idea. And that's usually because we're not with them 24 hours, 7 days a week. There's so many other things going on that we don't know what they bring in every time they're coming in and meeting with you. We don't know what they're bringing in with them that day, you know, what might be on their mind. So in addition to open-ended questions, so with the motivational interviewing format, there's this ratio about number of questions to reflections. So reflections is another type of speaking or communication tool to get people to continue to talk and help them to feel validated and affirmed in that process. So again, it's more than just listening, it's listening with a purpose. So it's listening in a way that's helping them to kind of work through this stuff. So sometimes people are like, what do you do in talk therapy? People just talk and that's supposed to help them get better, and it's like, you should try it. It actually gets there, but the magic is in the feeling validated, because by doing that, you're allowing the emotion to process. If folks don't feel their emotions get validated, then they get stuck. The emotion gets stuck. And then it just like creates layers and layers of stuff on top of that. And then you spend years trying to get down to what the core emotion is. And part of those layers, thoughts come in. And then you've got to wrestle with thoughts and emotions in order to just get down to the real healing that needs to happen with some things. Did you guys see Inside Out, that Pixar movie about emotions?
Yes, cute too.
Did you like it?
I didn't watch it. My son watched
Oh.
it. But
yeah. I thought they did a good job about talking about like early formative experiences and how, you know, like her core beliefs, those balls, I don't know if you saw those,
yeah.
How, you know, how there's emotions there that are either adaptive or not adaptive, and they're important to get to, you know. And so that's one of the challenges, I think, in working with patients, is that there's just a wealth of stuff going on, and you got to, you know, take the time to find out what might be happening for them through open-ended questions and reflections, which are very affirming. So does anybody know what a reflection is? So it's kind of like when someone says something and you're not introducing anything new, you're almost like summarizing what they've said. And that validates that to them, that you've heard them and that you understand. And sometimes you get it wrong, and that's okay. You know, sometimes you have to kind of guess, like, did you mean this or that? And if they get to correct you, that's fine. And then you're just kind of trying to get as close to where they're at as possible. So reflection is almost like a paraphrase. It can be also a summary of what they've said. It could be like a lot of times, especially with MI, it kind of came about in the substance use treatment domain because people are often torn about their substance use. You know, it's like they want to quit, but they can't. So they talk about that ambivalence. And so a reflection can be, wow, so on the one hand, you know, you really just want to accept this treatment and kind of go forward with it. But on the other hand, you're worried about what impact it's going to have on your family, or you're worrying about the financial piece. You know, so it's those kind of reflections after they've talked are a nice way to get them to feel that you've heard what they've got to say and that you're somebody that understands them. And that speaks volumes. I can't underscore that enough. I see it all the time in my work. Okay, let's move forward. So the asking about the hard questions, if somebody does express hopelessness or depressed mood, asking whether or not they've also had thoughts about hurting themselves. And sometimes people are afraid to ask those questions, partly because they feel like they're going to cause it if it's not there, or they don't have the time to sit with somebody if somebody is having thoughts of hurting themselves. But have a plan, you know, for how you're going to work with somebody who is suicidal. You know, whether it's, you know, a quick referral to the social worker or somebody to kind of come in and help with that patient at that time, or referring them to a counselor, something like that. But have your own plan to how you're going to deal with that, so you're not afraid to ask the question. So you know, okay, if this does pop up, this is what I'm going to do to help. You want to ask them if they have a plan, if they have means. Were they intending to do it anytime soon? Those are all indicators that their risk is high when it comes to actually following through on thoughts of suicide. So people can have what we call suicidal ideation, which are just thoughts without a plan or intention or a clear. And that doesn't mean that you need to admit them to the hospital. Sometimes it's just normal, right? And just allowing them to talk about that. You know, so you feel so bad right now that you could end your life. Yeah, I really feel bad, but I'm not going to do it. I just, you know, what else do I have to live for right now? You know, but so just engaging in that conversation to help them talk through those thoughts can be very helpful, and without you having to worry, like, if they're not thinking about an actual plan, chances are they're not at high risk of actually attempting suicide. Asking about finances, kind of our main theme for today. So specifically finding out about that, and it sounds like it's on your guys' distress scale, so that's great. Do you feel worried or stressed about any of the costs related to your care? And how has the cancer impacted you and or your family's financial situation? Those are some really good targeted questions. And we talked about those for your screeners, so we can go forward there. So the active listening, the reflections, the summarizing are all the things that are going to help you to be able to empathize with the person, to normalize what they're going through, and to really kind of help them deal with all the psychological issues that are going on. Okay, I think I covered enough of that. So referring, you guys all have like people that you refer to when you feel like somebody is in need of some more longer term care. Okay, good. Behavioral health providers have different specialties, so you just want to make sure that you refer them to somebody who's familiar with kind of the health arena, health psychology, or cancer care. And who is the best person just depends on what system you're in. We're available at Iolo Hui. We have a downtown office near Ala Moana, so if you guys want to refer to us, we are available. Okay.